We will welcome our new guest. It is actually speaking, this new guest is one of the catastrophically most dangerous. When I say most dangerous, means it is such an aggressor that once it is there, along with dementia, there is 100% likelihood of death. And secondly, why I am saying it is dangerous aggressor is it causes rapidly progressive dementia followed by rapid death. When I say rapidly progressive, from the onset of clinical signs or symptoms to dementia is usually less than 1 year, and death occurs within months, latest 1 to 1.5 years. So we welcome this dangerous villain, Creutzfeldt-Jakob disease. Welcome.
Hello, sir.
Hello. I am overwhelmed and I am actually intimidated because, as we know, you are one of the diseases which is fatal, and you have been invited in this podcast because one of your classical predominant presentation is only dementia, and that D will lead to D, the final D, that is death. And in the midline, in the temporal profile, that other things are there, you will be highlighting us. So welcome again to this podcast.
Thank you, sir.
From your own mouth, again, I ask everybody, you just introduce yourself. From where do you come and what is
Sir,
it?
basically, I am a disease who comes from a large family of diseases. Those collectively are called as prion diseases.
Prion diseases.
Yes, sir.
And what is this prion?
Sir, basically, prion, we are not caused by any virus or bacteria. It is a protein in your own body which has altered its configuration and has become self-propagatory. It is the protein which has become self-propagatory, and that causes the disease.
Okay, the protein is becoming self-propagatory and it is transmitting yourself when it is propagatory.
Yes, sir.
So it is behaving like an infection.
Yes, sir.
So maybe that's why it is known as the proteinaceous infectious particle.
Yes, sir.
And here there is no infective agent. It is
Yes.
the protein,
Yes.
protein itself.
Yes.
Okay, you just mentioned that you come from this prion-related protein disorders. That means there are other disorders that can caused by these prionopathies.
Yes, sir.
You are the boss, no doubt about it. Creutzfeldt-Jakob disease. Any other disease that can come as prion protein?
Sir, the predominant diseases which are in my family are myself, then fetal familial insomnia, sporadic familial insomnia, then Kuru and Gerstmann-Straussler-Schnitzler's disease. We are the flag bearer of this family.
Prion family.
Yes, sir.
Prion disorders.
Yes.
Prion disorders. And
Yes.
amongst them, dementia is the most common feature of CJD.
Yes, sir. For me it is the classical feature.
Okay. Do you have any other variants of yourselves, other guises, other groups?
Of course, sir. I have 4 different types. The most common which is found throughout the world is sporadic. Sporadic CJD accounts for 90% of total CJDs. Second is hydrogenic CJD. Third is genetic. And it is my pleasure to tell you that we have a new flag bearer of the family. You must all have heard about it. Variant CJD.
Variant CJD. I had done some research in variant CJD. Maybe 1 or 2 decades back. I can't remember the exact time. But this variant CJD had an outbreak in England, and predominantly it affected the younger generation of population.
Yes, sir. Because in the younger generation there is a trend of eating canned beef.
And that time, yes.
Yes, sir. And that has caused a new variant of my CJD.
Affecting the younger generation.
Yes, sir.
And as you mentioned, the canned beef, that means the bovine form of a disease
That has
which was
converted to
earlier
human.
not seen in the humans.
Yes.
After that canned beef consumption, humans got affected.
Yes, sir.
Bovine spongiferum
Yes.
encephalopathy, which if I am correct,
Yes, sir.
that began to affect the human population. That is why the most dangerous that thing happened.
Yes, yes.
With due respect.
Yes.
And catastrophic respect and due respect, you all created this devastation that time. So these are your variants. Can you highlight about, we will be highlighting mainly on the CJD of the sporadic form which you will talk, and especially the iatrogenic part. I am little bit more interested because we are all we want to know that what iatrogenic cause can be there for CJD. If I am correct, you correct me. From some transplantation of grafts,
Yes.
corneal transplantation,
Yes.
dura mater graft concentration,
Yes.
grafting, infectious particle can be transmissible. And especially in the endocrine field, what I have researched that the transplantation or the injections
Human
of
growth
human
hormone.
growth hormone, yes, human growth hormone. And again, the deep electrodes what we use in neurology, electrodes, if they are infected also, they can be
They can
transmitted.
transmit.
Okay, that is the iatrogenic
Yes,
cause.
sir.
Now we will come down to the epidemiological part. Kindly elaborate on the epidemiological part.
Sir, basically I am not a very common disease. Throughout the world, if you study me, 1 in 1 million person will have CJD. And the accounting death in the world will be 1 in 5,000 death will be because of the CJD. I also have some age related predisposition, like as the age of a person increases, the chances of person getting CJD also increases, and it reaches its peak when the person is in 60s.
Okay, okay.
This is basically my epidemiological graph.
What is the pathophysiology? What do you do in the brain from the molecular level to morphological level?
Yes, sir. So this is a very interesting part, sir. Basically, the PRP, conversion of PRP into a different substance, is basic pathophysiology behind the
Here
occurrence.
what you have mentioned maybe.
Yes, sir.
PRPC.
PRPC is the
Normal.
inherent molecule in our body that has predominant alpha helix in it.
Okay, okay.
There is a mutation in PRPC which converts PRPC into PRPSC,
SC.
which has predominant beta structure in it.
And that's the
this beta structure. This beta structure is the basic of CJD.
So this is the transmittable
yes,
protein.
yes, sir.
This
This
is
is the
abnormal which
transmittable.
transmits.
Yes, sir.
Okay, okay, okay. So PRPC to PRPSC, fantastic. Go ahead with other. Then what do you do?
Basically, on gross pathology, you won't find anything. If you see brain grossly in an affected CJD person, there won't be any changes. But here is a trick. When you do light microscopy of that specimens affected with CJD, you will form spongiform denaturation.
Spongiform
Denaturation. That is vacuolation basically. Along with this, there could be astrocyte gliosis.
Spongiform changes
Along with
astrogliosis.
astrogliosis. These are pathophysiologic changes. That is a hallmark of pathologic hallmark for me.
Okay, okay, okay.
Basically, it could be found in putamen, cerebral cortex, cerebellum, everywhere. But basic thing is when you isolate it, it could be in a very small amount.
Okay.
That is the thing.
Okay, okay, okay. Now, can you highlight on the clinical features?
Yes, sir. Clinical feature is the most important part for me
Yeah,
because
I know that.
some people may have prodromal symptoms. Prodromal symptoms includes vertigo, weight loss, easy fatigability, altered sleep cycle. It may or may not be present, sir. But the neurological and psychiatric symptoms are the one which are hallmark for me. It includes depression, anxiety, insomnia, visual hallucination, and these symptoms, sir, along the course of the disease in 1 year progresses to the hallmark symptom for me, and that is rapidly progressive dementia.
That is the reason.
That is the most important clinical feature for me, sir.
Because of that reason only I am still intimidated by you, and that is the thing.
Sir, along with this dementia, the other second part is the second clinical feature.
Okay, sir. What happened, sir?
Sir,
What
this
happened?
is the second classical feature of mine. Statal myoclonus.
Startle myoclonus.
Yes, sir.
Startle myoclonus.
Sir, any input from light or sound that is sudden will cause statal myoclonus in patient affected with CJD. This is also hallmark symptom of mine, sir.
Fantastic, fantastic. So, rapidly progressive dementia, startle myoclonus, one of the hallmark clinical features. Okay, okay, sir. Then how could we diagnose you?
Sir, diagnosis is basically for me, the diagnosis is like we will go from back in the time also.
Yes.
So as I told you, PRP-SC is hallmark. So isolating PRP-SC by proteolysis in the tissue affected by CJD was the gold standard test earlier.
Okay.
But I told you earlier also it would be in a very small quantity. So there has been recent advances also. But we have to discuss from start.
Yes.
So that was the first pioneer testing PRP-SC isolation from affected. Then second is sir, MRI, neuroimaging. Neuroimaging plays a very important role for my diagnosis, sir. And in neuroimaging, flare sequence and diffusion weighted imaging will have hyper intensity. Along with this, the hallmark feature is cortical ribboning in
Cortical
MRI.
ribboning.
Yes, sir.
Okay.
Cortical
The cortex
ribboning
becomes ribbon-like.
Yes, sir. It becomes
But the
ribbon-like.
young girls when they use ribbons in their
Yes,
like
yes,
this.
sir. Yes, sir. And that is a very hallmark thing for me, sir. The next test is CSF analysis. In CSF analysis, it would be mostly normal, like acellular CSF. It may sometimes show raised proteins and raised tau in CSF.
Tau.
Yes, sir. But one specific thing, stress protein 14-3-3.
14-3-3.
Yes, sir. It would be raised in CSF. Though it is a non-specific marker, sir. It can be increased in any disease of my family. But it gives a hint that
obviously.
prion disease is there.
Yeah.
And sir, new advances is, as we have told, that this disease has some new advances. So the most recent test for diagnosing me is RT-QUIC. That is
RT quick.
Yes, sir. Real time
Walking
induced conversion test.
Yeah.
Real time walking induced conversion test.
Okay.
Yes, sir.
This name is.
Sir,
What do we do? What is the principle of this test?
Yes, sir. In this, what we do, we have seen that molecular basis PRP is the basic thing. So what we do, we know that PRP-SC is in very small form, but we also know that PRP-SC is a self-propagatory protein. So what we do, we clone PRP-SC in E. coli, in vitro.
PRPC, the normal.
Yes, sir.
normal.
PRPC. And then add the infected or suspected CJD patient sample in it, and after vigorous shaking, as it has self-propagatory feature, so this PRPC in E. coli will also be converted to PRP-SC, and then via immune fluorescence we detect it, and this has become now the gold standard test for
Most sensitive.
yes, sir, most sensitive test.
RT quick for CJD.
Yes, sir.
Fantastic.
And finally, not but last the least, brain biopsy. Sir.
Biopsy.
Brain biopsy is there.
What do we see in brain biopsy?
Sir, in brain biopsy,
You have
as we have
already
discussed in
highlighted.
pathology,
Spongiform
spongiform
changes.
degeneration and astrocyte gliosis.
Astrogliosis.
Yes, sir.
Does EEG have any role in your diagnosis?
Yes, sir. EEG also have a role in my diagnosis. There would be random electrical spikes.
Okay.
Random electrical spikes. Rather than I would mention this, a 60-year-old patient visiting you with triad like myoclonus, dementia, and
Get an EEG done.
is a EEG showing this
Periodic sharp
complexes.
waves.
Periodic
sharp waves in EEG.
You must suspect me.
Then I
You
should go
must
for all
suspect.
this investigation.
Yes.
Okay. So, any treatment, sir? What I can say, it's just a mockery of things. We all know you.
I am
Just for
invincible,
the
sir.
sake of saying it. Any treatment?
No, sir. No treatment. Only supportive treatment. You can only counsel the patient. There is no treatment for me. Once I am
100%
in, from onset to the symptom appearance occurs in within 1 year, and from dementia to death is within 9 months. Sir. 9 months.
Okay. It was really quite an overwhelming discussion, and no doubt a lot of things we knew about you. Your fantastic deliverance and fantastic contribution to our knowledge and for our audience. Thank you, sir.
Thank you so much, sir. Thank you for inviting, sir.
Okay, so things are very exhaustive now. But we are enjoying. So let's invite our next guest, Mr. Normal Pressure Hydrocephalus. Okay, welcome. Mr. Normal Pressure Hydrocephalus, हाजिर हो. Yes, sir.
तो आ रहा हूँ.
But there is no magnet inside. Are you wearing iron shoes or something? Or there is no magnetism here.
अरे रुको, आ रहा हूँ ना.
Yes, sir. Yes, sir. Yes, sir. चेयर ले आओ भाई. चेयर ले आओ. Sir, this is our podcast, sir. You remember we have invited you, you accepted our invitation, and I think there is some problem in your walking. You are not able to initiate a walk. Sir, you remember us? You have to talk a lot about yourself now, sir. Kindly sit, sir.
बैठता हूँ, बैठता हूँ.
Yes, yes, sir. Should I sit with your permission, sir?
बैठ बैठ.
हाँ सर, आप बैठ जाइए सर. आप I think I should help you, sir. You are comfortable? Hello, sir is coming under screen. Everything is fine? Yes, sir. I am your host. I am sorry, Acharya, your host, sir. Thank you for, again I am thanking you for accepting our invitation to this podcast of dementias. And you are one of the elite members of the dementia family. Yes, yes.
मुझे जाना है.
अरे जाना है. ये जाना है मतलब कब से? मतलब
सर इनको बार बार पेशाब को
मैं सुनाई नहीं दे रहा सर. क्या बोले?
दिन में बार बार पेशाब को जाते हैं सर. तो कम से कम 20 से 25 बार सर.
ओके. कपड़े में भी हो जाता है क्या?
जी सर.
Urinary incontinence, magnetic gate. Yeah, you are acting fantastic, sir. You are affecting our population. You are acting fantastic. I think soon you will be in your mood to talk with us. ले जाओ भाई सर को. ले जाओ भाई. अरे सर को तो लग रहा है हो गया है यहाँ पे. हो गया है यहाँ पे, थोड़ा गड़बड़ हो गया. ठीक है, जल्दी जल्दी जाके चेंज करा के लाओ. हो गया है यहाँ. He is incontinent, huh? Okay.
पहचाना मैं कौन है?
Yes, yes. There is no confusion, sir. Pehchana, and now the way you showed how you affect our patients. Now you are in your real mood and real form, Mr. Normal Pressure Hydrocephalus. Welcome again.
Thank you, thank you.
Yes, sir. So we will start our podcast.
Yeah.
We have already seen your drama. Fantastic magnetic gait, shuffling gait, inability to initiate the walking process, then urinary incontinence, and the dementic part you are looking either. I don't know. We will come to know about it. Okay, sir. Again, as per the protocol, algorithmic discussion. May I again introduce yourself? A little bit, two sentences.
See, I am a neurological condition which is characterized by increased production of cerebrospinal fluid and accumulation in the ventricles, causing ventricular megaly. Yeah.
And we are fortunate that you do not increase the intracranial pressure. So normal pressure, but hydrocephalus. A lot of poetic, paradoxical poetry. Yes, 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 yes. Okay, sir. What is the epidemiology, sir?
Generally, I affect around 0.5 to 2% of the population, but my major target is our older people, which impacts 5% of the dementia in the older people is caused by me. But physicians diagnose me as degenerative dementia mistakenly.
Oh, that is a point of concern.
Yeah.
They think that the clinical presentation is due to some degenerative dementia, but actually it is accumulation of cerebrospinal fluid and hydrocephalus. Okay, okay, okay. Yes. Sir, what is the pathophysiology? You will elaborate it a little bit more.
Generally, I am usually idiopathic. I come without any cause to anyone. But I may be followed by certain conditions such as subarachnoid hemorrhage, infections, trauma, tumors, or arachnoid granulations, and anything, everything which disrupt the flow of CSF and causing delayed in absorption. So that CSF get accumulated in the ventricles, causing ventriculomegaly, compressing the adjacent structures, mostly paraventricular white matter and the fibers and tracts which are responsible for gait, cognitive function and urinary incontinence.
So because of involvement of these fibers, the clinical presentation.
Yes, yes.
And these ventriculomegaly compress and affect these fibers, so the
Yeah.
clinical features. And you also told that there are secondary forms also.
Yeah.
Associated some illnesses like subarachnoid hemorrhage and infections. Okay. So can you elaborate on the clinical presentation a little bit?
Yeah, the clinical presentation of my part usually can be described in a name as Hakim-Adams triad.
Hakim-Adams triad. Okay, Hakim-Adams triad.
It has three features mainly. One is gait disturbance. It is the earliest and commonest presentation in which patient will have magnetic gait, so that he couldn't initiate the walk. Even after initiating walk, he will walk in a shuffling pattern for some distance, again goes into a state of magnetism. You might have seen now where
Yeah, I saw that. May I interpret you just, can it be called as gait apraxia?
it could, but
Forgetfulness of the learned memory, you know, how
Yes,
here
yes.
the person was walking after the normal person
Yes,
had
yes.
tuberculosis, forgets how to walk. It's a gait apraxia.
it's like at least 20-30 kilonewtons of energy acting on a body, and it's magnetic. You will be
You are stuck to the
ground.
Okay, yes,
You can
yes.
start the movement
Okay.
even if you want.
This is about the gait.
Okay.
Then about next.
Then we have the dementia cognitive decline part, in which you have difficulty in executive functions, slowness and impaired attention. You'll have difficulty in initiating the movements. You have bradyphrenia, slowness of thoughts.
Bradyphrenia, slowness of thoughts.
Slowness of thoughts.
Okay.
Even though I impact memory, but the impact of memory is very less compared to my fellow parts. As King Alzheimer's has more impacts
Yeah,
memory.
we have met him. We had the opportunity to meet the great Alzheimer's.
Yes, I impact only little bit of the memory, that too on the recall memory.
Recall part.
Recall.
part.
That too in the later stages.
That too in the latter stages. Earliest is the gait.
Gait.
Okay. Then the urinary incontinence.
That is a final and end stage where I cause increase in frequency and hesitancy and cause urinary incontinence, so that your life becomes very chaotic and miserable.
Yeah, I understand that. How do you diagnose? How you can diagnose?
You must have a highest clinical suspicion to diagnose with. So in any elderly, rather than misdiagnosing them as
That is the most important part. Yes, sir.
misdiagnosing degenerative dementia,
Yeah.
they should
Like
have-
somebody can be confused with Parkinson's disease
Yeah.
looking at the gait itself.
Yeah.
Okay.
But initially I have magnetic gait. You should have highest clinical suspicion,
Yes.
or then you will followed by the neuroimaging.
Yeah.
In neuroimaging, you can use two indices. I think you already read about.
Yeah, I have researched this, sir.
Yeah, first one is Evans index.
Yes.
In the axial sections of the MRI or CT, you will check about the maximum diameter of the frontal horns of the lateral ventricles.
Okay.
You can see this
That is X.
represented as X.
X.
Maximum diameter of the frontal horns of the lateral ventricle ratioed with maximum diameter of the skull at the same level in the axial section.
Okay.
This is known as Evans index. If it is greater than 0.3, then you could suspect I have already come to you.
Yes. Any other neuroimaging, sir?
And other is in
Yes.
MRI, this is not acute conversion angle. Normally between the anterior commission posterior commissure, the angle between the anterior commission
The
and
anterior commission and the posterior commission level, this is the corona, this is
this is the coronal section.
yeah.
In the coronal section, anterior commission, posterior
The
commission
lateral ventricles.
of the lateral ventricle, the angle in normal people will be 100 to 120 degrees.
That means you are referring about this angle. If I again show the audience, this is for the Evans index.
That is the axial section, this is coronal
Yeah, in the corner section, the same lateral ventricles, and this angle we are talking about here, between the lateral ventricles at the level of anterior commissure.
Yes, posterior
Correct, sir?
yes.
Okay. What is the normal level? Yes, sir, yeah.
Normal level is 100 to 120,
Yeah.
but in cases of NPH, they will have decreases to 50 and 80. The more acute becomes, the more toxic I am.
Okay, sir. Yes. Well said, sir. So, how can we treat you? Is there any treatment? Yes.
Yes, I am treatable
That is a
and I
good
am
news.
reversible,
Believe me, that is a good news.
and I am reversible also.
Believe me, that is a good news, and we are fortunate, sir. Again, a special thanks to you because majority of the persons of the elite group, there is no treatment.
So
And for our audience, this is to be highlighted because in neurology, there are very limited situations which are treatable. So the take-home message will be after this conference, and again I will be repeating it somewhere, some time, that do not miss the treatable causes because we have few treatable causes. Go ahead with yes, sir. Thank you again.
Diagnosing me is very important because I am reversible,
Yes.
maybe partially or completely. If you drain 50 to 60 ml of CSF after diagnosing me, my symptoms may be reversible.
Okay.
You could see the dementia is being controlled. Cognitive functions are improving initially,
Okay.
followed by guilt. Just by draining the CSF. So diagnosing is that important.
No doubt, sir. No doubt, sir. No doubt. So, sir, if I summarize, if you allow me,
And-
yeah.
After draining, if you see the improvement of symptoms, for continuous drainage, you could go for ventriculoperitoneal shunt.
Yes.
After you install the shunt, there will be continuous drainage of CSF and all the symptoms will partially disappear and patient will be a better.
That's enough. There is partial disappearance also. Oh, what an interview, sir. Let me summarize. You can highlight again if I am wrong somewhere. So, pathophysiology is basically it is a CSF overproduction
Yeah.
and leading to ventriculomegaly and leading to compression of the fibers which are responsible for the cognitive part and for the gait part and for the urinary fibers tracts. So the Haken's triad you told about gait apraxia, dementia and urinary incontinence, elderly people, classical triad, magnetic gait, shuffling gait. Keep a differential diagnosis of Mr. Parkinson's or early dementia with Parkinson's like Lewy body, Mr. Lewy body dementia, or as you told from some other neurodegenerative condition affecting gait. You keep the possibility, but you are the boss because as a physician I will give utmost respect to you because you're a treatable cause. Then I should go for the neuroimaging if I have a high index of suspicion. There I will calculate the Evans index and the acute callosal angle. Normally it will be very acute, like in your case it will be 50 to 80 degrees. Normally it is 100 to 120 degrees. At level of anterior and posterior commissure, if you take coronal section and the acute angles between the lateral ventricles, if I am correct, and here the frontal horns of the lateral ventricle divided by the inner table, maximum diameter of inner table of the skull. If it is more than 3.3, then the treatment is CSF plating. 50 to 60, there will be dramatic improvement. And if I can put in a shunt, ventriculoperitoneal shunt or something, there is some respite to us. Thank you again, sir, enlightening us about yourself. Thank you very much. Thank you. Without wasting time, alcoholic dementia. Welcome. He is already intoxicated. I had requested him not to get intoxicated during the podcast. How I will take this interview now? Mr. Alcoholic dementia. Unfortunate. I had called you for the podcast and you are still in an intoxicated form.
Thank you, sir. Thank you, sir, for inviting me.
Okay.
This is to show you that I can, the memory can be involved in acute as well as in chronic form.
Oh, beautiful. I'm sorry. So you wanted to tell our audience that in acute form also you can involve memory, and in the chronic part you can also involve memory.
Yes.
Fantastic idea. Can you just please introduce again?
Yes, sir. I can cause cognitive impairment, which results from the chronic alcohol consumption.
Yes. Memory part that will be involved in chronic alcohol consumption. Yes, and you cause dementia.
Yes.
What is the basic pathophysiology?
Sir, I add direct neurotoxicity to neurons and white matter of the brain. Thiamine deficiency, which causes which causes Wernicke's encephalopathy in acute form and Korsakoff's syndrome in chronic cause.
Okay, let me just please, I'm not correlating. Yes, yes. So yourself, alcohol itself is a toxic substance to the brain, that we got it. And again, you highlighted about the Wernicke's encephalopathy part, which is acute.
Which is
As we all know, it's a medical emergency.
More severe form.
Yeah, it's a medical emergency.
Yes.
Wernicke's encephalopathy, there will be some involvement apart from the other clinical features of Wernicke's encephalopathy,
Yes.
like acute delirium, acute confusion and memory impairment, and neuropathy,
Yes.
and cranial nerve involvement, like we know that lateral rectus palsy and all these things.
Yes.
Along with that, that is your acute form, you involve the memory, and you told about the Korsakoff syndrome,
Yes.
Korsakoff psychosis.
Which is
If I am not wrong, that is that confabulation part,
Yes, sir. Yes.
where the story goes, again the reality goes, then replaced by some stories, then the reality.
Yes.
That is the confabulation is the key word here.
Yes.
Fantastic. So basically, in a chronic form, you just want to say that per se alcohol is the boss and it can cause neurologic damage,
Yes.
leading to memory dysfunction.
Yes.
Okay.
So in
So
later stages, the diffuse cortical and subcortical involvement, atrophy of the brain,
Yes.
which affecting predominantly in frontal and mammillary bodies,
frontal and mammillary, so these are region specific.
regions.
Though there is a diffuse cortical atrophy, alcohol induced, and the predominant areas you told the frontal cortex and the mammillary body. Yes, mammillary body. Fantastic. Okay. So how can we differentiate you from other dementias? The one thing is very clear, when we take a history of alcoholism, it will be there. But still, there are certain other conditions. How I can differentiate you?
Yes, sir. I usually prominently involves executive dysfunction.
Executive dysfunction. Executive skills.
Yes, sir.
Working pattern and daily activities. Okay.
Then I may have history, chronic alcoholism history.
Yes, that is the way I highlighted. When we take history, the person will be chronic alcoholic,
Yes.
and there will be loss of executive functions.
And thirdly, the most important part, I am reversible.
That is the great news. That is actually the impact factor of this podcast. We want to highlight the guests who are reversible. So you are one of the causes that are reversible cause. Need not to be emphasized. Stop alcohol. That is maybe your message to the
Yes.
audience here. Okay, so these are the different. Any other disease or this can be differentiated from any other condition? Like maybe any differential diagnosis of dementia may come under this scale, I think. And only the history of alcoholism, when you are there, I can think that probably this is the good news, that it is alcoholic dementia and abstinence of alcohol will help. Okay, what is the treatment basically? How can we get treatment?
Complete alcohol in abstinence.
Yes, that is the first message.
First message.
Stop alcohol.
Then nutritional supports with thiamine.
Nutritional deficiencies.
Nutritional deficiencies with thiamine. The high dose of thiamine before glucose infusion is given in acute forms like Wernicke's encephalopathy.
Oh yeah, this is very interesting to you highlighted. So in acute Wernicke's encephalopathy, we have to first give thiamine, IV infusion of thiamine or shot of thiamine followed by glucose. Why this?
So thiamine is a cofactor which is involved in glucose synthesis. Giving thiamine without glucose, which causes
Excessive. I know you are intoxicated, but yes, I am making things easy for you. Don't worry. So yes, as you told, thiamine is a cofactor for metabolism of glucose. So here, if I am not giving thiamine first and giving glucose, then the biochemical cycle is extracting more thiamine and there is already no thiamine. So maybe the neurological involvement is deteriorating and becoming more catastrophic. So thiamine followed by glucose. Fantastic. And for the chronic form, as you have told, stop alcohol.
and other supportive therapies like cognitive rehabilitation can be used.
Cognitive rehabilitation therapy, and is the only message is stop alcohol. Thank you. Thank you very much.
Thank you.
Alcoholic dementia. You can go through now.